We are live.
Thank you. A very good evening to everyone and welcome to the 21st episode of the AIOS ARC webinar for postgraduate students. And today we'll be having an entire session on case presentation of short cases. So we are very, very delighted to have and proud privilege of having examiners who are very, very esteemed. Professor Dr. Vibhuti Sinha sir, who is the Professor and Chief of the Regional Institute of Ophthalmology, Patna. We welcome you, sir. We also have Dr. Pankaj Sharma sir, who is the Professor and Head of Department of Ophthalmology, SMS Medical College, Jaipur. Welcome you, sir. We'll be having Dr. Kavita Kumar, who is the Professor, Department of Ophthalmology, Gandhi Medical College, Bhopal. I think she'll be just joining shortly. We are also very happy that the mentors have joined us. So we are having two main institutes, the AIMS Bhubaneswar and the Armed Forces Medical College, Pune. So we have mentors, Dr. Sucheta Parija, who is the Professor and Head of Department of AIMS Bhubaneswar. Welcome you, ma'am. We have Dr. Brutendu Morana, who is the Assistant Professor at AIMS Bhubaneswar. We welcome you, sir. We also have Dr. Vikas Ambia, who is the Professor of the AFMC College, Pune. Welcome you, sir. I think he's yet to join. And Dr. Divya Kochar, who is the Assistant Professor of the AFMC College, Pune. We welcome you, ma'am. And presenting the two short cases are our two young dynamic residents. We have Dr. Anmol Kar, who is the resident of AIMS Bhubaneswar, who is going to present on ectopia lentis, and Dr. Ananya Chatterjee, who is the resident at AFMC Pune. She will be presenting on pseudoexfoliation. So we welcome both of you, wishing you all the best, and let's start right away. So our first speaker is going to be Dr. Anmol Kar. Please share your presentation.
Okay. Good evening, everyone.
Yeah, please start sharing. Yeah.
Yes, ma'am.
Yeah. We can see your presentation.
Yes, ma'am. Today I'll be discussing a case regarding ectopia lentis. Here I present a case of 27-year-old male resident of Bhadrak, Odisha, who came to us with the chief complaint of diminution of vision in both the eyes since 1 year. The patient was apparently all right 1 year back. To begin with, he noticed the worsening of vision in both the eyes, even with the use of glasses. Am I audible? The screen is
Yes.
not moving.
Yes, we can hear you clearly.
Yes, you're
Please
audible.
continue. Yeah.
Okay. The patient was apparently all right 1 year back. To begin with, he noticed worsening of vision in both eyes, even with the use of glasses, which was insidious in onset, gradually progressive and painless, and not associated with any redness, photophobia, diplopia, flashes, or floaters. For this, he had consulted in a local hospital outside, where he has been documented as bilateral inferonasal subluxated cataract, and right eye phacoemulsification was done 11 months back. Post-operatively, the patient is not on any spectacle correction. In the history of past illness, the patient has a history of irregular use of glasses since 6 years of age. There was no documents available with the patient regarding the past refractive status. The history of joint pain and range of movement restriction in multiple joints in the upper body was noted. There was history of occasional palpitation and dyspnea present. He was not a diagnosed case of any collagen vascular disorder, hypertension, or diabetes. The patient has not been screened for any congenital syndrome in the past, and there was no history of any ocular trauma. In the treatment history, currently the patient is not on any systemic or ocular medication. In the family history, there was no significant relevant history found, like consanguinity or mental retardation or premature death in the family. Coming to the examination, starting with the general examination, the patient was conscious, oriented to time, place, and person, thin built with tall stature. There was no pallor, icterus, cyanosis, or clubbing noted. The vitals were stable, the BP being 110 by 74 millimeters of mercury. The pulse was 70 beats per minute, regular in rhythm, good in volume. Coming to the systemic examination, on the central nervous system examination, the higher mental functions and cranial nerves were normal. The respiratory system, bilateral vesicular breath sound was present with no added sounds. Cardiovascular system showed S1, S2 present with pansystolic murmur noted. Coming to ophthalmic examination, the head posture was straight, looking forward. The visual acuity in the right eye being 624, improving to 618 with pinhole. And in the left eye, it was counting finger 3 meter with no improvement through pinhole. The near vision in right eye was N24 and left eye was N36. The intraocular pressure measured in morning 11 a.m. By Goldman applanation tonometer. So 12 mercury in the right eye and 14 mercury in the left eye. The extraocular movements were full and free in all 9 gazes in both the eyes and were painless. The gaze was orthophoric in both the eyes. The orbit margins were palpable, continuous, non-tender, with no evidence of proptosis in both the eyes. The leads were normal. The rho plus was negative in both the eyes. In the anterior segment, conjunctiva was normal in both the eyes. Cornea was clear in both the eyes with corneal diameter measuring vertically 11.5 mm and horizontally 12 mm in both the eyes. The sclera was normal. The anterior chambers was normal depth with no cells or flare or vitreous prolapse in the anterior chamber. The pupil in the right eye was keyhole appearance with extension at 9 o'clock position. It was reactive to light with no evidence of relative afferent pupillary defect. The left eye pupil was also round, regular reactive with no relative afferent pupillary defect. The iris in the right eye showed atrophy at 12 o'clock, 3 o'clock, and 5 o'clock position. And in the left eye, the iris was normal. On pharmacological pupil dilation for further examination, the pupil was poorly reacting in both the eyes with only 4 dilation. The lens in the right eye showed aphakia with posterior capsule remnants present nasally from 12 o'clock to 6 o'clock position. In the left eye, the lens was subluxated and cataractous, the subluxation being inferonasal, and the extent was approximately 6 clock hours. Exactly the clock hour extent was couldn't be appreciated due to poor pupillary dilation. The stretched zonules were noted, and there was no pigments or exfoliation over the lens. On the posterior segment examination, the media was clear in the right eye with media grade 0, and in the left eye, the media was hazy with media grade 2. The optic discs were tilted and with temporal crescent in both the eyes. The macula showed dull foveal reflex in both the eyes. The peripheral retina had limited visibility due to the poor pupillary dilation and so tessellated background. The blood vessels were normal with normal arteriovenous ratio of 2 is to 3. On further ocular investigations, the B scan in both the eyes showed bilateral enlarged axial length, and there was no history of retinal detachment, vitreous hemorrhage, or posterior stapyloma. The A scan was done to note the axial length, which showed right eye 30.83 millimeters, and in the left eye it was 30.15 millimeters. Keratometry values of K1 in the right eye was 41.06 at 66 degree, and in the left eye was 40.33 at 136 degree, and the K2 values were in the right eye 41.46 at 156 and in the left eye 40.72 at 46 degree. The retinoscopy done with 0.5% tropicamide in the right eye showed horizontal axis plus 5 diopter spherical, and in the vertical axis plus 6 diopters. The left eye retinoscopy couldn't be done due to the central lenticular opacity. The patient showed an acceptance of plus 1.75 diopter spherical in the right eye, giving best corrected visual acuity of 618. Central corneal thickness in the right eye was 542 microns and in the left eye was 548 microns. The gonioscopy in both the eyes showed ciliary body band was seen in both all the quadrants, giving Sappho's grade 4. So the differential diagnosis was made of both eye high myopia with right eye aphakia and left eye ectopia lentis secondary to either hereditary conditions like Marfan syndrome or homocystinuria or the acquired condition of high myopia. So the ancillary investigations were done like the Marfan or Marfanoid habitus screening, where we found that patient had tall stature with arm span more than height. Long slender digits were there showing arachnodactyly. The thumb sign was positive and the wrist sign was also positive. There was no high arched palate or scoliosis or intellectual debility. On 2D echocardiography, we found dilated aortic root and aortic arch. The mitral valve prolapse was there with mild mitral and tricuspid regurgitation and enlarged left ventricle. So the modified Gaines criteria was fulfilled due to the 2D echocardiographically proven cardiac lesion as well as ocular lens subluxation. Blood investigation, we did serum homocysteine level, which was within normal limit. So we diagnosed the case as bilateral high myopia with right eye aphakia and left eye ectopia lentis secondary to Marfan syndrome. Coming to the management, the systemic management is important. The cardiology consultation was done and the proper medications were started and cardiology clearance for surgery was also taken. The orthopedic consultation was done for the musculoskeletal abnormalities. The patient was counseled for a genetic screening and counseling of the family members. The ocular management, we plan for the surgical approach because the lens is cataractous and the subluxation is large, involving more than 6 clock hours. Our plan of surgery for the left eye is exact plan we can find out at the OT table after knowing the correct extent of the lens subluxation, but we have planned for careful phacoemulsification using iris hook, followed by capsular bag fixation using Sioni ring, and then posterior chamber IOL implantation. But in case if the bag cannot be salvaged, we will do lensectomy by pars plana or limbal approach with anterior vitrectomy followed by IOL implantation, either iris claw lens or retro iris fixation of artisan IOL. For the right eye, after the left eye surgery, we may plan for spectacle correction or secondary IOL. Thank you.
Yeah, excellent presentation. Can you stop sharing?
Yes, ma'am.
Yeah. Shall we have both the presentations and then discussion? Hello.
I think we can discuss right now.
Yeah, I think we can discuss one by one, right?
Yeah.
Yeah. Welcome, Dr. Kavita.
Hello.
Hello.
Yeah. I was there, but I was not able to join, so I was listening on some.
Oh, so sorry, ma'am. I was not able to see you. That is why.
Yeah. Okay.
Yes. So the questions can now be put to the resident.
Now you have done the axial length and keratometry. You have not calculated what IOL power you would have desired to put in the eye, because you are planning for surgery on the left eye. So have you done some IOL power calculations?
Yeah. Yes, sir. For the left eye, we have done biometry.
Yes. So what IOL power have you decided for the left eye? Because you're planning for surgery for the left eye. Also, in the right eye, you have shown a retinoscopy of +6 and +5.
Yes,
but
sir.
acceptance you have said is +1.75. Either there is something wrong in the retinoscopy or because retinoscopy is one of the most objective clinical examinations. Whatever you do, you can just check yourself and do a subjective verification there and then. So I think you should revisit your retinoscopy, because +5 and +6 with an acceptance of 1.75 doesn't look normal.
Yes. Okay, sir.
Either you did it very close.
Yeah, I was just going to ask, what was the distance at which you did the retinoscopy? So that,
2/3 of the meters.
yeah, and yeah. So can you just repeat the diagnosis for me, Doctor? I'm forgetting the name. Yeah, I would like
Yes,
to know the diagnosis once again.
ma'am, it was, should I share the screen again?
If you know, if you can repeat it just for me.
Bilateral high myopia. The patient was bilateral high myopia with right eye aphakia and left eye subluxation of lens, ectopia lentis, maybe secondary to Marfan syndrome.
Okay. So that means you are saying that the right eye, the patient has just simple high myopia, and this left eye he has got that subluxation because of Marfan syndrome.
Right eye also might be subluxation due to Marfan and has been operated and has been left aphakic. It was iatrogenic.
Yes, so that is what I wanted to stress here, because you categorically said that both eyes myopia with left eye Marfan syndrome. As you all know very well, that Marfan syndrome is a disease which affects the connective tissues, and usually it cannot be a uniocular disease. So the patient is of Marfan syndromes, very well
Yes.
proved by all your investigations. Hence, the right eye was also must have been a subluxated lid. That is why the patient is aphakic. Had the
Yes.
lens been normal, the surgeon would have put an IUL. So, so both eyes, the eyes are affected due to Marfan syndrome. And my question, second question to you is, what are the other signs of myopia which you have seen in right eye or left eye, or both the eyes? Because apart from axial length, you have not looking to the axial length, it is about 30 millimeters, right?
Yes, ma'am.
So 30 millimeter axial length is a high myopia, according to me, as the retinoscopy and acceptance also shows that the aphakic eye is just accepting
Just
+1 or +2. So this person must be having a myopia somewhere around 15 or 16 diopters. So
Yes.
a person having 15, 16 diopters of myopia, what are the other features you examined in the eye, which are important as far as the visual prognosis now and further is important?
Fundus examination is important. Due to the poor visibility, we couldn't see the far periphery. At the macular region, only we could see the tessellated background and the tilted disc and the temporal crescent, which are the features of myopic fundus. And we did a B scan to rule out the retinal detachment or any posterior staphyloma present. But in these cases, we should rule out the retinal tear or any lattice degeneration if present. The fundus features should be ruled out.
So even in the aphakic eye, you could not see the periphery of the fundus?
Yes, due to the poor dilation, we could see, but there was no retinal hole or degeneration noted till the extent of visibility.
So, as ma'am has said, the primary diagnosis is Marfan syndrome. The primary diagnosis is not high myopia, it is Marfan syndrome with high myopia and one eye aphakia because of this surgical aphakia, and the other eye there is ectopia. So, any difference between ectopia lentis and traumatic subluxation? Why we call it as ectopia? What is the meaning of ectopia? Ectopic.
Ectopia is malposition of lens.
So it could be traumatic also.
Yes,
So
ectopia.
Yes, ectopia lentis is a term which is reserved for such congenital anomalies of the zonules, and it was previously thought, just like an ectopic pregnancy, that the lens develops in an abnormal position, but it's not like that. It develops in the normal position, but due to the poor zonule, so it is not a true or a correct term. So ectopia, it was traditionally used for crystalline lens, which it was thought to be developing in an abnormal position. But we know that now that the zonules are weak because of the poor extracellular matrix throughout the body. So the lens then becomes in an abnormal position. So in Marfan, so what is the usual type of subluxation which is noted?
Most common is superotemporal.
But it can be infero-nasal
But it can be
also. But in this case, it is not a typical superotemporal.
It is infero-nasal, sir.
Can I put you?
So how will you?
Yeah.
Yes, sir.
No, sir. Sir, please go ahead.
No, I was just saying, what do you plan to do for the left eye? Why do you want to put an IUL? Like you said, your primary aim would be to put an IUL in the eye. Any
If
reason
we can
behind
salvage the bag, then we will put a IOL in the posterior chamber.
So, exactly. Now I come to the first question. What was the IOL power that was calculated for this eye?
So for a constant of 118.7, it was around plus 6.50 diopter lens.
So what are the complications of doing a cataract surgery in such a case? Expected, which ma'am was also hinting at, that did you try to see the fundus because of the high myopia? What do you expect that complications to happen in such a case after doing
retinal
cataract surgery?
Detachment can occur.
Yes. So would you still like to put an IUL in such a case?
If we can fix the bag with Sioni ring, then
yes,
give the stability there to the lens, then we can put a posterior capsule.
Posterior chamber IUL, posterior capsule.
Yes.
Sorry.
Yeah.
Posterior chamber.
And in the right eye, you have aphakia with what? A dense posterior capsular opacity. What is that? What is that? You cannot say aphakia with the posterior capsular opacity, of course. So what is there in the central of the pupillary area? I could see a white, dense, fibrous plaque in the pupil, and you are saying aphakia. So that means there is no posterior capsule if there is aphakia, hopefully. So what is that? Either it is a failed extracapsular cataract extraction, which has left some parts of posterior capsule, or what is that? How can you describe
it was
that?
Probably, actually, the patient was documented as right eye phacoemulsification. So might be the phacoemulsification be tried and tried to remove the whole posterior capsule, and there might be failure.
So that
might
could be a fibrous capsule along with the hyaloid, which has kept a thick fibrous. So if you are putting IOL in one eye, say you successfully put an IOL or say SIG diopter in the left eye, how are you going to manage the right eye then? Because the patient needs a binocular vision. Right eye is aphakic, left eye you are making pseudophakic. So what do you plan next for the right eye?
Right eye, we can plan for secondary IOL. Either iris, claw lens, or artisan.
So with that thick membrane sitting right in the center of the pupil, do you think that secondary iris claw lens would work? You need to do something else before putting an IOL, right?
Capsulotomy.
You have to clear the visual axis.
Capsulotomy is needed.
Will you use the word capsulotomy for it or something else? Yes, you are rightly saying that you want to clear the visual axis, isn't it? So if you want to clear the visual axis in this patient, what procedure would you adopt?
Laser.
No.
You can take some of the other approaches also for clearing. Related to this, just want to ask one question. There was some kind of the pupillary distortion also present in the right eye.
Yes, sir.
Could you explain what was the reason of that pupillary distortion? And why the gonioscopy was normal and you could see up to periphery? What was there which was doing this?
Perhaps due to the poor dilation in the previous surgery, iris hooks might be used, or some sphincter tear might have happened.
So sphincter tear will appear. It can be visualized. Sphincter tear or some other kind of trauma can be visualized from the iris. Was there any kind of atrophy also in the iris? Because that was not mentioned in your workup. Okay, the posterior plaque was present in the other quadrant of that pupillary area. Could there be some other reason of pupillary distortion in this case? Was vitreous phase intact or was...
Yes, so what sir is trying to hint is the pupil was not distorted, it was peaked. So what are the causes of a
there was
peaking
no
of pupil post-operatively?
any vitreous prolapse into the anterior chamber can cause streak of vitreous, thus not allowing the pupil to constrict properly and causing peaking of the pupil.
So that was not there in this case?
No, sir.
Anterior chamber was perfectly clear from the vitreous?
Yes, sir. There was no vitreous in the anterior chamber.
How you can visualize those vitreous strands into the anterior chamber? What are the ways of evaluating?
Post-operative or intraoperative?
During your evaluation, what was how you can evaluate that anterior chamber was perfectly clear? What methodology of slit lamp evaluation could have been utilized for seeing those vitreous strands into the anterior chamber?
So suppose sir is saying there is vitreous in anterior chamber and you want to prove him right or wrong. What method of examination would you do to see whether there is vitreous in anterior chamber? In other words,
will you use diffuse illumination, focal illumination, a slit, or what type of slit lamp examination would you choose?
Sometimes a very fine vitreous strand could be missed very easily, going even up to the incision line. So that's why I'm asking this question. And because those vitreous strands are detrimental to the result of the whole surgery, they can cause a lot of complications in the post-operative phase also. So that is very important. It has to be identified. Anyway, what are the other complications which can occur if there is a vitreous strand going up to the margin? What are the complications which can occur in this patient?
Raised IOP can be there by angle, blocking the angle.
Okay.
No, if there's a single strand which is going from the vitreous up to the wound area, what complication could it lead to?
Endothelial touch can occur and
no,
okay, so one is endothelial.
So I'm not saying a full vitreous. Yes, vitreocorneal touch is one thing, but if it's a single strand, what that traction can do?
This patient is already
retinal detachment or
yes, absolutely.
Retinal detachment.
So one is retinal detachment, the other is a vitreous wick.
And then posterior
chronic cystoid macular edema.
Yes. Sir is absolutely right into saying that.
Yes.
So these complications need to be evaluated before going into any further kind of management, because what you have seen, they need to be correlated. You have you have presented this case very well, but there are some lacunae because your finding need to be corroborated with each finding need to be correlating to each other. That's when the story will become complete, and then your whole case presentation will be complete. So another question is, you have evaluated and you can see up to the peripheral retina. You're saying into your presentation that the peripheral blood vessels are normal. The AV ratios and everything is normal, but you couldn't describe the disc analysis because this patient is already predisposed to some other kind of changes also on the disc. So that's very important. So once your finding says that you can see the periphery, and in natural course, you could have evaluated and you could have elaborated upon the disc also. That's what I want to say. Sir, you can ask, sir. Pankaj, sir.
Just one more thing. Why do you want to stick to putting an IOL in this case? What every surgeon has his own preference for whatever reason. But what I feel is, patient is already high myope. You can go via pass planner, leave the patient aphakic. So use a +3 or +4 diopter spectacle, but then any posterior segment complication develops can be dealt more easily with a aphakic patient. Regarding the loss of compartmentalization from the posterior and anterior segment, it is already lost because the lens is already subluxated. So preserving the bag, if it is possible, then it's okay. But I don't think the bag can be preserved in such a large subluxation. What I feel is, would high myope, we can just do a pass plan approach and leave the patient aphakic, clear the anterior vitreous, and then we can further assess periodically if there's any posterior segment complication and can be dealt with, because the glasses will hardly be of +3 or +4 diopter expected with such a high axial length. But it's a personal choice, obviously.
Yeah.
It's open to the house. And
yeah, no, I think what sir is saying is absolutely correct. His acceptance is just 1.5 diopter in the phakic eye, and the other eye, it looks looking to the clock hours of the capsular dehiscence. I mean the zonulaces. It seems difficult that one would be able to implant an IOL. Maybe it's ideal that we leave the patient aphakic and put him on maybe aphakic lenses or contact lenses, and later after complete evaluation of the posterior segment, if everything seems to be okay, or if the posterior segment pathologies are treated, he can be maybe put with secondary iris claw lenses if the iris allows, or scleral fixation lenses depending upon the condition of the posterior segment. Because in this patient, after when we do the lensectomy, vitrectomy, again there is a great danger to the retina, because we'll be disturbing the whole vitreoretinal phase, which is right now stable. But if we are doing lensectomy, vitrectomy, we are disturbing the phase. There are chances that the retina is disturbed and he might land up in some serious retinal issues. So that is our point. I think Dr. Anagha, you are impatient that we should start the second case.
Yes, because it's 8:30.
Yeah.
Well, time for the
Yes, sure.
president.
So anyway, the case was very well presented, all the findings very well documented.
Yes.
And this is what we expect from the postgraduate students, that the first thing we want you to learn is pick up the abnormality which are there in the eyes. The rest of your life, you will learn how to put things into places. It's a jigsaw puzzle. So you should be able to put the things in, pick up the abnormalities, so that later on you can analyze them and put them. Yeah. Thank you so much.
Thank you.
Thank you.
So thank you, Dr. Anmol, and thank you to all the examiners. Lovely discussion. So we'll move on to the second speaker now. Dr. Ananya, please share your presentation.
Yes, ma'am.
Yes, you can go on to the PPT mode. Yeah, we can see your presentation.
Okay, thank you, ma'am. Good evening, everyone. I am Dr. Ananya, third year resident, Armed Forces Medical College, Pune. At the outset, I would like to thank AIOS ARC for providing me this platform, and my sincere gratitude to my mentors, Ambia sir, Divya ma'am, Vijay sir, and Ashok sir, under whose guidance I have prepared this presentation. 68 years old female, resident of Pune, homemaker by profession, informant is self, and reliability is fair. Presented with the chief complaints of diminution of vision of both eyes, left eye, more than right eye, since last 6 months. She was apparently asymptomatic 6 months back when she started developing diminution of vision of both eyes, left eye, more than right eye, which was gradual in onset painless, and progressive in nature. Initially, she was able to see objects all around, but the vision gradually diminished, and since last 1 month, she was able to see objects only at 2 to 3 meters distance. There was no history of pain, redness, watering, intolerance to light, aggravation of symptoms with exercise, floaters or flashes, distortion of objects, altered color perception, wearing of glasses, no past history of ocular trauma or surgery, or chronic use of topical medications. She was a known case of type 2 diabetes mellitus and was on oral hypoglycemic agents since last 5 years with good compliance. There was no history of hypertension, tuberculosis, or any other systemic diseases. She was a non-smoker, teetotaler, consumed mixed diet, and had normal bowel, bladder, and sleep habits. Family history, not contributory. Treatment history, nothing significant except for her oral hypoglycemic agents. General and systemic examination was essentially within normal limit. Ocular examination, distant visual acuity unaided in the right eye was 636, improving to 624 with pinhole. Refraction with tropicamide 0.5% at 2/3 meter distant showed plus 0.5 diopter in the horizontal axis and plus 1 diopter in the vertical axis. Best corrected visual acuity in the right eye was 624 with minus 0.75 diopter sphere. Now coming to the left eye, distant visual acuity unaided of the left eye was 560, improving to 660 with pinhole. Refraction with tropicamide 0.5% at 2/3 meter distance showed plus 0.5 diopter in both vertical and horizontal axis. Best corrected visual acuity in the left eye was 660 with minus 1 diopter sphere. Near visual acuity in right and left eye was N18 and N24 with plus 2.5 diopter sphere. Head posture and ocular alignment was normal. Extraocular movement was free and full in all gazes. Slit lamp evaluation of the right eye showed lids and adnexa normal, conjunctiva normal, cornea was clear and lustrous, anterior chamber normal in depth with Van Herrick's grade 4 and normal in contents. Iris normal in color and pattern. No neovascularization was noted on the iris or on the pupillary border. Pupil was central, circular, reacting to both direct and consensual light reflex. 7 mm dilatation was noted after application of mydriatics. Lens, cataract grade was nuclear opalescence grade 3, nuclear color grade 3, cortical 2 and P1 as per LOCS3 classification system. This is the corneal diagram of the right eye depicting cataractous lens. Distant direct ophthalmoscopy of the right eye. Glow was present in the primary gaze and in all 4 quadrants. Right eye fundus evaluation. Media was slightly hazy. Optic disc normal in size, shape, color and margin with normal neuroretinal rim. Cup disc ratio was 0.4:1. Vessels were normal in course and caliber with AV ratio of 2:3. General fundus was within normal limit. Foveal reflex was present in the macula. Slit lamp evaluation left eye. Lids and adnexa normal. Conjunctiva was normal. Cornea was clear and lustrous with normal epithelium and stroma. However, pigment deposits was present over the central part of the corneal endothelium. Anterior chamber was normal in depth with Van Herrick's grade 4 and normal in contents. Iris showed small whitish flecks seen on the pupillary margin. However, no transillumination, defect or iridodonesis was visible. Pupil was central, circular, sluggishly reacting to both direct and consensual light reflex. 5 mm dilatation was noted after application of mydriatics. Lens showed white powdery ring deposits, which was present on the anterior lens capsule. Target sign was seen on dilatation of the pupil. Cataract grade was nuclear opalescence grade 4, nuclear color 4, cortical 2, P1 as per LOCS 3 classification system. No zonular dehiscence or phacodonesis was seen. This is the corneal diagram of the left eye depicting pigment deposits present on the corneal endothelium, and the optical section is showing white flecks present on the pupillary margin and on the anterior lens capsule with cataractous lens. Distant direct ophthalmoscopy of the left eye, glow was present in the primary gaze and in all 4 quadrants. Left eye fundus evaluation, media was slightly hazy. Optic disc, vertical elongation of the cup was seen with normal color and margin. Localized thinning of superior and inferior neuroretinal rim with peripapillary atrophy involving the beta zone was seen inferiorly. Laminar dot was also visible with no optic disc hemorrhage. Cup disc ratio was 0.8:1. Cup disc ratio asymmetry was observed between the 2 eyes. Vessels normal in course and caliber with AV ratio 2:3. General fundus was within normal limit. Foveal reflex was present in the macula. Intraocular pressure measurement by Goldmann applanation tonometry at 1000 hours showed 18 and 32 mm of mercury in the right and left eye respectively. Gonioscopy, which was done before dilated evaluation in a dimly lit room, the right eye showing posterior pigmented part of the trabecular meshwork was visible in all the 4 quadrants. Gonioscopic grade 2 was seen as per the Schaeffer's classification system. Left eye, gonioscopic grade 2 was again observed as per the Schaeffer's classification system. Posterior pigmented part of the trabecular meshwork was visible in all the 4 quadrants. Increased pigmentation of the trabecular meshwork was seen in all quadrants. Irregular pigmentation was also noted along the Schwalbe's line in the superior and inferior quadrants, suggestive of Sampolis's line. Based on the history and clinical examination, my diagnosis is immature senile cataract, both eyes, left eye more than right eye, and pseudo-exfoliative glaucoma, left eye. Thank you.
I'm sorry, do you have any clinical photographs of the patient? Because all this is just pictorial depiction.
Yes, sir. Sir, I
Hello.
Am I audible, sir?
Yes, you are audible.
Sir,
I have some clinical pictures.
No, sir, I haven't kept any clinical pictures of the same, sir.
I think you should have kept some clinical pictures because presentation is all right, but I'm not able to relate with the patient. It's all pictorial.
Sir.
So in cases, it's a good thing that whatever you describe in your books, when you present, either the patient should be there or their picture should be there for us to assess the condition of the patient. Because what you are seeing and what we would like to see in the patient, it's different. So can you repeat the diagnosis for me once again, please?
Yes, ma'am. It is immature senile cataract, both eye, left eye more than right eye, and pseudo-exfoliative glaucoma, left eye.
So that means you say that there is pseudo-exfoliation only in left eye?
Yes, ma'am.
So if I want you to know whether the right eye is susceptible or on the verge of going into pseudo-exfoliation, what do you see in the right eye? According to you right now, the right eye is absolutely normal.
Yes, ma'am.
So are there any signs which suggest that this might also proceed to pseudo-exfoliation in future?
Ma'am, the early signs of pseudo-exfoliative material, early signs include depositions in the peripheral part of the anterior lens capsule in the form of radial striations. So this can be seen only when the pupil is fully dilated or the pseudoexfoliative material is also deposited initially in the zonules and in the ciliary body. So we can get a ultrasound biomicroscopy done to visualize the same, to detect whether it has increased suspicion of developing the pseudoexfoliative glaucoma, since the chances of bilaterality is very high when one eye has already developed.
Have you done gonioscopy of the right eye as well?
Yes, ma'am, I have done gonioscopy.
What are the findings in gonioscopy?
Ma'am, in the right eye, the gonioscopy findings were the posterior part of the posterior pigmented part of the trabecular meshwork was visible in all the 4 quadrants. However, no increased pigmentation of the trabecular meshwork or Schwalbe's line was seen in the right eye. However, in the left eye, the posterior part of the pigmented trabecular meshwork was visible in all the 4 quadrants, but there was increased pigmentation seen in the trabecular meshwork in all the 4 quadrants, with increased pigmentation of the Schwalbe's line was seen in the superior and inferior quadrants.
So right eye, you don't see any Sempoli's line?
No, ma'am.
Okay. And secondly, my next question regarding your diagnosis was, you said both eyes immature cataract.
Yes, ma'am.
So that means there is no nuclear sclerosis in this eye? Both eyes?
Ma'am, I said my diagnosis was immature senile cataract. Yes, ma'am. There was, as per the LOCS 3 classification system, ma'am, there was in the right eye, it was nuclear opalescence grade 3, nuclear color grade 3, P2 and C1 and P2, sir, ma'am. And in the left eye, it was grade 5, ma'am, nuclear opalescence, nuclear color grade 5, with cortical 2 and posterior subcapsular 1.
So that means you say that the cortical cataract is more than the nuclear opalescence. That is why you labeled it as immature cataract. Because the senile cataract, we have 2 clear grades. One is nuclear sclerosis and the other one is cortical cataract, isn't it?
Ma'am.
So what you described in your findings and what you are narrating in your diagnosis, they do not match. You're saying nuclear sclerosis grade 3 and grade 4. And with that, you're saying that this is senile immature cataract. So if your diagnosis looks more like a cortical cataract, whereas your findings go more in favor of nuclear sclerosis. Got my point?
Ma'am.
Sir, anyone, sir? Sir.
So what I wanted to ask, the best corrected visual acuity in the right eye is 636, the left eye is 6/60. So ophthalmology is nothing but explanation of poor visual acuity. If you can explain why the patient cannot see, you have learned ophthalmology. Can you tell me why the patient is not improving beyond 636 in the right eye and 660 in the left eye?
So the possible reason for the diminution of vision in the right eye, first would be cataract grade, sir, depending on the grade. It was.
But you could do. Sorry, sir. Excuse me. But you could do a retinoscopy quite well.
Yes, sir.
And you showed a distant the direct in which you could see the glow in all the 4 quadrants.
Yes, sir.
There was no no posterior capsular opacification. Cortical spokes also you did not show. So any other reason why the vision was 636? Because so this amount of cataract, see now the thing is there, because and nowadays everyone has got a smartphone and a slit lamp, and it's very easy to click a clinical photograph on a slit lamp with your smartphone, so that the discussion becomes more meaningful. Because right now we are just talking on hypothetical basis. What you have seen, we have not seen.
Sir.
So fundus was normal.
Yes, sir.
In the right eye?
Sir, though the patient was diabetic.
Macula was normal?
Yes, sir.
Ananya,
okay.
can I take a further question from Pankaj sir? Pankaj sir is asking how we could assess what will be the visual outcome post-surgery also.
Yes.
So this patient, what you have narrated is having a best corrected visual acuity of say 6/36 in the right eye after giving the proper refraction. So post-surgery, are we expecting similar kind of vision, or we can assess something by which we can narrate that this patient might get better vision post-operatively? There are very simple kind of tests also. You can do it with a pinhole. You can do it by putting +3 diopter pinhole. Because this pupil was 7 mm, you could do the retinoscopy, you could have easily assessed the BCVA for this patient and assess what was happening at the posterior pole also to prognosticate the patient. But this was little surprising that this patient was having a clear-cut picture of the pseudo-exfoliation in the right eye, whereas the left eye, whereas the right eye was absolutely normal, except what you said, that the pupillary dilatation was not beyond 7 millimeter. So there was some kind of pupillary rigidity was developing into this patient. We might have missed some of the signs early, which you narrated. But what you said that UBM could have been utilized to identify the deposition of these pseudo-exfoliating material in jonules or the ciliary body. Can you explain how that is possible? Can it be done on a UBM? Is it possible, or?
Sir, it can be done, sir. And other than that, sir, and ASOCT.
What will be the sign which will be present on UBM to assess that these pseudo-exfoliating material is present in the jonules?
Sir, we can detect those deposits, small deposit, white flecks of deposits, which can be present either in the beginning of the zonules or on the ciliary body, sir. And apart from that, sir, we can also get an ASOCT done for this patient, sir.
So what will be the information we'll be getting by ASOCT?
ASOCT, whether there is any zonular weakness or because of the deposition of the pseudo-exfoliative material.
You rightly said ASOCT can be done, but one very important investigation we couldn't do in this case was specular, because these patients have endothelial distortion and endothelial changes. So endothelial count and the changes occurring in the endothelium is one important thing to be performed even before we move on for the surgeries also.
Sir,
what are the changes which will be present in the endothelium in a case of pseudo-exfoliation?
There will be decrease in the endothelial cell count, and apart from that, there will be changes in the shape and size, often giving atypical corneal guttata can be present in cases of pseudo-exfoliative syndrome.
So what are the differential diagnoses based on what changes you saw in the left eye? What are the differential diagnoses we could think of if we forget about the target lesion?
Sir, my first differential diagnosis will be pigment dispersion syndrome or pigmentary glaucoma in left eye. Second would be, sir, amyloidosis, and it can be true capsular delamination, sir.
Okay, so coming to the pigmentary glaucoma, if you say this is a pigmentary glaucoma, and so what will be the difference between the gonioscopy of pigmentary glaucoma and in the case of pseudoexfoliation syndrome?
In cases of pigmentary glaucoma, if you do a gonioscopy, then the deposition in the trabecular meshwork, the increased pigmentation in the trabecular meshwork will be homogeneous. Whereas in cases of pseudoexfoliative syndrome, it will be blotchy and irregular, uneven deposition in the trabecular meshwork. And sample-AC line can be seen in both pigmentary glaucoma as well as in pseudoexfoliative syndrome. So the pigmentation in the trabecular meshwork can be used to differentiate between the two, sir, on gonioscopy.
And what are the implications of identifying that this patient is having a poor pupillary dilatation? What will be the further implication of that?
Since the patient was having poor pupillary dilatation and she was having cataract also. So whenever we will plan the patient for cataract surgery, there will be certain preoperative, intraoperative and postoperative complication. In preoperative complication, there will be poor pupillary dilatation, and because of the pseudoexfoliative material, there can be increased IOP, which we could see in this patient. In the intraoperative phase, there can be zonular weakness leading to lens subluxation, or there can be capsular tear during phacoemulsification and vitreous loss. And in the postoperative period, such patients are prone to develop increased IOP and postoperative inflammation. And in the late phase, we can even expect capsular phimosis, posterior capsular opacification, and lens decentration, late IOL decentration.
What was the age of patient?
68, sir.
68. So it's quite late. 68 usually have bilateral kind of presentation, but this patient was very characteristically having uniocular pseudoexfoliative glaucoma, whereas the right eye was absolutely normal even in term of. So did you go ahead with the glaucoma investigations also?
Yes, that was my next question.
Sir.
Oh.
Yes, sir. Sir, after initial diagnosis, clinical diagnosis, we did a baseline visual field analysis and OCT RNFL for this patient, sir. And visual field defects was not present in this patient in both right and left eye.
So wait, excuse me. You have till now we have not seen any objective finding either in the if you have done a visual field, we should be presented. It should be there in your presentation. If you have done an OCT RNFL, it should be there because that is the very objective finding. It is not your subjective, what you have seen. It is what has come out from the patient. So do you have that visual field examination?
Sir, I do have that, sir, but I haven't kept it in this, sir. Because
so that should have been, because it's basically a case of glaucoma.
Sir.
One eye, it is 0.8 cupping, other eye is 0.4. So for a complete, what sir has hinted and what you should know is what is the complete glaucoma evaluation, because to me, this looks less of a cataract and more of a case of glaucoma, because the cataract is not that much and vision is affected more. Fundus is otherwise you're saying all right. So if the vision is affected due to glaucoma, what other investigations apart from your visual field you said you have done OCT RNFL, we don't know, that should have been included, but just your IOP, single IOP you have taken, one is 18 in the right eye and I think 32 in the left eye.
Yes, sir.
1000 hours. I really like that 1000 hours,
sir,
because you are from the army background. But what extra should have been done?
Sir, diurnal, to assess the diurnal variation, sir.
Yes, because definitely left eye is glaucomatous. A diurnal variation should have been done in the right eye also, because now our focus is to prevent visual loss in the right eye also, which may be glaucomatous. Okay, it may be having a high IOP in some time of the day. So visual fields and OCT RNFL is not a very specific test. I don't know why everybody is going after OCT RNFL, but visual fields and diurnal variation are the two basic tests should be done for every patient, so that we know, because the IOP is the only modifiable treatment in glaucoma. You cannot treat the RNFL, you cannot treat any the cupping. You can only reduce the IOP to prevent damage in the glaucoma, right? So the glaucoma evaluation should have been the primary thing in your case. That's what I feel, and that is, I think, what has caused the visual loss in this case. Regarding the whatever you have said about what we should take care during surgery, it's perfectly fine in a pseudoexfoliation syndrome. We expect all those complications. We expect a poor dilatation. We expect a zonular dehiscence. We expect such complications during surgery. That we should anticipate. One more thing, you have said that in the left eye, the pupil was 5 millimeters, but there was no zonular dehiscence. Can you say there is no zonular dehiscence with a 5 mm pupil? What is the diameter of the lens, crystalline lens? Normal crystalline lens, what is the diameter?
Sir, 6.5, sir.
No. It is 10 mm. The crystalline lens inside the eye is about.
Sir.
So, what is the extent of the zonule on that 10 mm lens? How much anteriorly the zonules are attached on the lens? Do you know the normal anatomy? to what extent do the zonules come on the anterior capsule? In a 10 mm, they come to about 2 to 2.5 mm all around. So the central area which is left is about 6 mm. So with a 5 mm pupil, you will not be able to say that there is zonular dehiscence or not.
Sir.
You can have an indirect evidence that there is no phacodonesis. That you can see iridodonesis. But to see a zonular dehiscence, the pupil has to be dilated at least 7 mm. So that is the thing which, there is in your clinical finding not correlating with the thing. So you should always have a photograph so that we can make our own visual image regarding the treatment and whatever discussion is going to be there.
Ananya, your clinical findings at the presentation was excellent, but as rightly said, Sir Pankaj sir has said that this patient was more likely to have glaucoma as a main reason, and this could have been taken care of. Because once you take up a case of glaucoma, then the disc analysis becomes very important. Even the clinical evaluation, the size of the disc has to be described very nicely. And so, can I ask, what are the slit lamp evaluation method of sizing the disc, and how we do categorize as small disc or a moderate size disc or a large disc? Because that has got implication. The right eye might be also having some kind of glaucomatous change which might have been missed.
Sir.
So you can use the slit lamp aperture for evaluating on 78D or 90D lenses on slit lamp biomicroscopy by using the length of the beam to evaluate the disc size. And by that, and by using the correction factor of 78D or 90D, we can actually assess the disc size. The other way is you can always go for OCT, and OCT is always going to give you some kind of information about the size of the disc. So what will be the next question? That what are the importance of the size of disc in glaucoma evaluation?
Sir, the disc, it can be physiologically, it can be a large disc. So to determine whether glaucoma is present or not, normally the disc is horizontally oval. So if the disc diameter increases more vertically than horizontally, then there is high suspicion that glaucoma can be there. So it is very important to judge both the disc diameter along with the cup diameter, and to assess the asymmetry between the cup disc ratio between the two. If one of the disc is more than 0.7, sir, or there is asymmetry between the two more than 0.2, then there is the diagnosis of
that will raise the alarm bell.
Sir.
So this patient might have glaucoma suspicion. But a small size disc with a small disc, a small cup also can have glaucoma. So that's what I wanted to tell you. That even a small size disc are very risky. Large disc, you can have a good NRR even with a 0.8 CD ratio. But in a small disc, even with a 0.5 CD ratio, you might have some kind of sectoral or quadritonopic defect on the OCT also. And that need to be percolated on the visual field estimation also. Coming back to visual field, if we have to perform a visual field of this patient, which program you are going to use and why?
So since we will be doing it as a baseline visual field analysis, so first we will be doing, sir, 30-2, CETA 30-2 first, and subsequently, if the patient turns out to be glaucomatous, to check the central field, we can do a 24-2. But first it will be 30-2 since we are doing it for the first time, sir.
So 30-2
usually, yeah. Please, sir.
Yes. Anything specific? One important thing in 30-2 in the setting that you will always choose. In such a case, always the fovea has to be on. We need the foveal decibel also. So many times you see the fovea is off. So we need a foveal the sensitivity also. So keep the fovea on in a 30-2. so that you can have an idea about the 30-degree field. So a peripheral nasal step will get, it will come out on a 30-2.
Even in the disc, neuroretinal rim, you can look for neuroretinal rim thinning apart from just the cup disc ratio, or they could be just a notch. So that also becomes an important sign. Madam, you are muted.
Ma'am,
Kavita?
muted.
Basically, what we wanted to, all of us wanted to take you to, that you have to first decide whether it's a primary glaucoma or it's a secondary glaucoma. That is the first thing which, and if it's a primary glaucoma, you have to worry about the other eye also. And secondary glaucoma, even if it is secondary glaucoma, it cannot be unilateral. So some or the other changes must have started in the previous eye, which we need to pick up early. We do not want to wait till 0.7 or 0.8 of cupping and more of the field changes. That is what we all want you to take your attention to. That the first thing here is mostly all the cases of pseudo exfoliation syndrome of pseudo exfoliation glaucoma are secondary open-angle glaucoma. And if you say that it's only one eye, then not the other eye, then you have to think about the primary open-angle glaucoma also, which has affected one eye first and maybe the other eye later on. And as sir has rightly said, Pankaj sir has rightly said, that in all the cases of glaucoma, we belong to the old school of thoughts. We start with the only modifiable factor, that is IOP. You have to screen the patient 2 hourly, at least for 2 occasions, to rule out that there is no major fluctuations, even if it is within normal limit. Maybe it is within 15 millimeter of mercury, but the fluctuation should not be more than 8 millimeter of mercury. Yes. Number 1. Number 2, keep a very, very close watch on the disc and the alarming signs on the disc. You know those 5 R's. And number 3, please see that if you see any changes in the disc and the nerve layer, which can be easily picked up by slit lamp, they coincide with the field effects. So these are the 3 important lessons which all students should take whenever you are examining a case of glaucoma, primary, especially primary.
I think you should have taken notes. Very excellently put by ma'am. Very nice.
Yes, sir. Glaucoma is my favorite topic, which I teach to my MBBS students for last 15 years. So, yes.
Yeah.
Okay, but it was well presented. Apart from the fact that in future, whenever you present a case, you must have as sir said, the clinical pictures of everything. Either the patient should be there. We usually do not present the case in our PG teaching without the patient and a slit lamp there, so that we confirm what the student is telling us. Because this is the time when we can tell you that this is right and this is wrong.
Yes, exactly.
Thank you everyone, and Dr. Ananya and Dr. Anmol, you've done a great job of presentation, and I'm sure that all the postgraduate students who have heard this webinar today, and with the pearls of wisdom that all our expert examiners have given us, thank you so much, Dr. Kavita ma'am, Dr. Vibhuti Sinha sir, Dr. Pankaj sir, for sparing your valuable time and giving us your special tips. Dr. Prashant is here. Dr. Prashant? Yeah.
Hello?
Yes.
Can you hear me? Yeah. Thank you, everyone. In fact, I was in the VRSI at Trivandrum. We were having meeting. That's why I missed upon.
Okay.
But whatever last part I could pick up, it went on fine. So I think we should congratulate the students first. Anaga, we should congratulate and pat the students first, and then thank everyone of them.
Yes.
Because both of them really did well.
Yeah. Their presentation was excellent.
Yes.
Very good presentation and great work by the mentors also. Thank you to the mentors.
They are just second year residents, not final year even. So that's a COVID badge. So they really did well.
Yeah.
I would also appreciate their courage that being the starter ophthalmologist, they presented in front of the big forum and the senior teachers. I mean, that was commendable. So don't keep on doing better. So next time,
That's
if you present, we would like to see you in a better stage. Yeah.
I always tell my students that you should keep on presenting and making mistakes so that you don't. Your first presentation should not be in your viva in the exam.
Yes.
You should. So you should know how to present these cases.
Yes. No, though they have presented really well. Yeah.
Very nice. Very nice. Thank you so much, everyone. Thank you.
Thank you, everyone. Thank you.
Thank you, ARC and Prashant Bhai for this wonderful initiative. Dr. Anga also.
Thank you.
Wonderful initiative.